Thank you for joining us for today's webinar, Deep Brain Stimulation and Parkinson's, the latest advancements 2024 edition. I'm Dr. Soania Mathur, family physician, PD advocate, Parkinson's patient for now over 25 years, and member of the board of directors, a proud member of the board of directors for the Davis-Phinney Foundation. And I have the pleasure of being your moderator today. This webinar is called the 2024 edition because we have had a conversation with our Parkinson's expert a few years ago, and there have obviously been advancements since that time in terms of technology. But what hasn't changed is that DBS continues to be a treatment option to manage the symptoms of Parkinson's, to improve quality of life in certain cases in those who are eligible for this intervention. To help us further explore this interesting topic is Dr. Joohi Jimenez-Shahed. She currently serves as the chair of the Science Advisory Board of the Davis-Phinney Foundation and is a member of the executive committee of the Parkinson Study Group. Her clinical focus is on the evaluation and management of adults and children with movement disorders, with a particular focus on the use of DBS, and her research also supports this field of study. Dr. Shahed, thank you for joining us today.
Nice to join you again, Sonia.
Thank you. Most people listening today, Dr. Shahed, have heard about DBS and have some working knowledge about the procedure, but perhaps you could remind us briefly about what DBS is, what symptoms are addressed, and when one should consider exploring it as a potential treatment option.
Yeah, that's a great way to start. So deep brain stimulation, as I'm sure many of our audience know, is an implanted device that is used to help control the symptoms of Parkinson's disease. And I think that's maybe an important place to start, which is that it is there to help control the symptoms of Parkinson's disease. It's not a replacement for medications. It is not a cure for Parkinson's disease. But it does help to manage symptoms better at a point when people are no longer getting the results that they need from medications in terms of being able to control those up and down fluctuations, maybe some tremor that is not really getting well controlled with medications. But it's just another tool in our toolbox to get the appropriate treatments and hopefully improve the quality of life, as you mentioned already. So DBS, the components of DBS are similar across the different manufacturers that we have. So there is a wire that has to be placed in the brain. This is sometimes referred to as a lead. It is also sometimes referred to as an electrode. But those electrodes have to be placed into very precise regions of the brain in order to help control the symptoms of Parkinson's disease. That electrode is then connected to an extension wire, and then the extension wire is connected to a battery. So the battery is also sometimes referred to as a neurostimulator. It's sometimes referred to as an implanted pulse generator. Lots of different terminology there, but essentially that's the thing that sits in the chest that supplies the electricity that then gets delivered into those deep brain structures. So all of the systems have these basic three components. And then on top of that, there is usually a patient controller that allows patients to interact with their stimulation depending on what the needs are. And then there is a programmer that the physician will have, or the clinician that is managing the deep brain stimulation therapy that can be used in the clinic to help set the settings, to help interrogate the device, to make sure that it's functioning properly, and to take advantage of all the different bells and whistles that are available on each individual device. So then what we do with all of that equipment, once it's implanted, is to try to program the system in order to deliver the therapy in the best way possible for that individual patient. There's a whole process to that we can talk about if you would like to get into that.
Sure. And from what I understand, this has been around for a while. It's been, I think, approved by the FDA in the US, I think, early 2000s. But from what I also understand from my reading, it was also around well before that, maybe used for different medical conditions to replace some of the other surgeries that were done for brain disorders at that time. Is that correct?
Yeah, you're absolutely correct. So last year marked the 30th anniversary of the first deep brain stimulator that was placed in the subthalamic nucleus for a patient with Parkinson's disease. So it's actually been around for 3 decades. And, as we're going to talk about today, the therapy that we have today in a lot of ways is very similar to what was originally envisioned, but there have been so many technological advances in the devices, in our approach to patients, in our understanding of how to treat patients with Parkinson's disease. So it really is kind of evolving as our understanding of the condition and of technology also changes over time.
Well, that makes sense. And how many people would you say, Dr. Shahed, are living with this option, or how many people sort of living with Parkinson's disease will eventually get DBS? Is there a percentage that you know?
Oh, that's a really hard question to answer. And I think, one of the things that we understand about Parkinson's, I'm sure everybody has heard this, right? I mean, the number of people with Parkinson's seems to be increasing, and we are seeing a lot of, this condition. The fact that it is a progressive condition means that people are going to go through stages in which they are probably experiencing some of the main symptoms that are treatable with deep brain stimulation. I think what we understand quite well is that there are definitely a lot more patients out there who could benefit from the therapy than are actually receiving the therapy. Okay. And that's, just work that we have to do on our part to educate people. So it's great that people are joining us today on this webinar and learning more about this therapy that is available and how it can help, because it always starts with that understanding and then moving on to maybe being evaluated for treatment.
Right, because I think that there is sometimes a perception in the community that this is kind of a last-ditch effort in order to control your symptoms. But as you mentioned, it doesn't necessarily have to be that way. Is that correct?
I think that's absolutely correct. And you're right that I think somebody maybe faced with an initial diagnosis of Parkinson's disease sort of maybe hears about what the trajectory of Parkinson's is going to be, the fact that there are medications, maybe they know that there are surgical treatments, but in their minds, perhaps it's very hard to consider that a surgical treatment might be necessary or might be helpful. But you're right. I think that the way that I like to explain it is that DBS is an excellent therapy for the right patient at the right time. And that might be different timing for different people. But generally speaking, we are thinking about using this therapy when people have already taken medications and have started a course of treatment, probably has taken some combination of medications, but is experiencing the effects of medications kicking in and wearing off. So that's something that we refer to as motor fluctuations. And then also the dyskinesias, which are those involuntary twisting movements that patients may experience at the peak dose of the effect of their medications. And then, as I also mentioned, when maybe tremor is a big symptom, but isn't being adequately or completely controlled with the medication.
Right. Thank you. That gives us sort of a baseline, I think, of knowledge that will be helpful when we further discuss the topics for this discussion. So let's dive a bit deeper and discuss the state of science on surgery technique. I have many friends that have undergone the procedure, and the one major difference that they seem to have is sometimes they're asleep for the procedure and others are potentially awake. Why is there a difference for one thing? Which is more common? And what are the advantages and disadvantages of both types?
Yeah, I think this sleep versus awake question certainly comes up a lot. And I think really the fundamental answer to that may depend on the team that you are working with. So there are many different ways to actually do the entire surgical procedure of deep brain stimulation. And if you talk to enough surgeons, you're going to find that each of these surgeons has their particular preferred method. And this is important because they need to be comfortable with what they're doing. They need to be able to achieve the results that they're hoping to achieve. And so different surgeons may have these different approaches. So that's certainly one aspect of it. And maybe there's a team that has trained particularly in the awake surgery, or maybe another team that has trained particularly in sleep surgery. I think increasingly we're seeing centers that can offer both. So, there is some choice in the matter that I think patients can be involved in. I don't know that there's really any significant evidence that shows that one approach is better than the other in terms of the specific outcomes. So in terms of being able to control symptoms of Parkinson's, et cetera, I think the basic thing is getting that electrode into the best pace possible, and then also being able to program it properly and to the best extent possible. So if that happens during an awake procedure or in a sleep procedure, I think the evidence suggests that these are pretty equivalent in being able to do that. And really what you want is a surgeon who is quite familiar with one or the other technique, whichever one they're going to be doing in your case. I think as far as other advantages, though, people do find the fact of having a brain surgery while awake on an operating table a little bit daunting. And so this, is an option that can be available for those individuals who either are, quite worried about that or just would rather do it that way. And if that's available to you, or if you have particular interest in preferring that the surgery be done asleep, then you can certainly search out a team that is able to do it that way. So there's no reason to think that one is better than the other, but there may be individual preferences that may point in one direction or another.
So there basically is not an advantage from a clinical standpoint, but it really depends on patient preference as well as the comfort level of the surgeon doing the surgery.
I think so. That's probably a good way to summarize it. I think for years and years and years, when this surgery, as we talked about over the last 30 years, right? I mean, the traditional way to do it was awake, yet we always know that there were patients who had trouble tolerating that procedure and, became either quite conscious, became anxious, excuse me.
Yeah.
Or maybe uncomfortable in some way or another. And so, it's great to have the option available for those individuals who really need it.
Just out of curiosity, do you know which one is done more commonly?
I think the awake procedures are probably still done more commonly. Mm-hmm. There are also different ways to do the asleep procedures. So, there's one technique that is completely under general anesthesia where patients are actually getting the procedure done through MRI guidance. And those certainly are restricted to those centers that have all of that equipment available. But other ways to do the procedure completely asleep don't require the MRI. So I think we're going to see more of that being available and being done. But I still think that the preference seems to be with the awake procedures.
Right. The other thing that people have undergone, the procedure seems to have is different is the number of surgeries. Do people get both sides done, or is it more one side? And if it is done on both sides, is it done at the same time, or is it done at different stages?
Yeah, again, I think this will depend to a certain extent on the patient and what symptoms the patient is experiencing, and also the team that is performing the procedure. So a common scenario would be to have two procedures done, one in which the brain electrodes are placed. So both sides, usually we are, because Parkinson's has a tendency, right? I mean, it may start out on one side, but then eventually over time, and certainly over the time course that you start experiencing the symptoms that we talked about are treatable with Parkinson's, patients are often experiencing bilateral or both-sided symptoms in their body. And so then you need to treat both sides. Mm-hmm. So a common way to do this would be to put both electrodes in at the same time, one in the right brain, one in the left brain, and then wait for that to sort of heal and for any, sort of other post-surgical type issues to resolve, and then to place a battery in a separate procedure. So that's probably one of the more common ways that it's done. Some centers will do one hemisphere, one side of the brain first, and then later the other side of the brain, and then in a third procedure, place the battery. Some centers may do one side of the brain and then 6 months later do the second side of the brain. So a lot of variability. And I think that's really just a conversation to have with the team when you are being evaluated for this to understand exactly how they go about doing it.
And is there any difference in terms of safety or outcome, whether or not the procedures are staggered or done at the same time?
I don't know that there certainly hasn't been a study very carefully examining the differences in outcomes between, what time is separating those individual procedures or how that is actually scheduled for the patient. I think that, again, certain centers may prefer to do it one way or the other because of these types of concerns, but I'm not aware of any real difference in safety. Some people may do sort of the separated procedures, like one hemisphere, one side of the brain first, and then another one later, because what they would really like is to let all the post-surgical changes resolve before they go in and place another electrode. And so the thought is that might lead to better accuracy perhaps, but that is not by any means requirement, and certainly I don't think has been proven to be superior in a very standardized way.
So, I mean, really, at the current time, there's really no reason other than patient and surgical preference to either go for the awake versus asleep surgery, the staggered versus done at the same time surgery, as we know it now.
Yeah, I think right now those are choices that are available, but may just reflect patient or team preferences and should be able to achieve the same results. You're absolutely
right. As I mentioned in my intro, we spoke about DBS advances a couple of years ago, and I'd like to spend some time now about what those advances are since last time we spoke. For example, adaptive DBS, that's a term that we hear quite often. How does adaptive DBS work?
So let's maybe start a little bit by understanding the difference of adaptive versus the alternative, which is continuous. So for all of this time, when a patient gets a deep brain stimulator device placed and we start programming it, that stimulation is on 24/7. So that's what we call continuous DBS. And whatever settings the clinician has programmed for that patient, that is the way that the stimulator is outputting and the stimulation that is delivering, it's constant. Now, there are certain variations on that. There are sometimes some reasons to do cycling where it turns on or off at set intervals, but those are not used very commonly. But generally speaking, continuous DBS is on all the time. So there are and have been some thoughts about whether or not this type of continuous stimulation is the best way to deliver DBS. You can imagine that, yes, a lot of people after deep brain stimulation reduce the amount of medications that they're taking, but they're still taking medications. And if they're in a situation where the medications are working and controlling their Parkinson's symptoms, maybe they don't need as much stimulation. And when the medication effect wears off, that would be a time where having more stimulation available might be more beneficial. So in the continuous stimulation paradigm, you really don't get to make those adjustments. It's just doing the same thing, whether or not your medications are on or whether your medications are off. And there are some concerns that perhaps that type of continuous stimulation may lead to either some overstimulation at certain points or perhaps lead to potential side effects, some of the long-term issues that we see with deep brain stimulation. The thought is that it might have something to do with the fact that we're continuously delivering this electrical current. The other thing that I think is a potential consideration with being able to modify stimulation is the battery usage and how much you're draining the battery with having that continuous level of stimulation versus being able to drop down a little bit of stimulation at certain times. So I think these are some of the main driving sort of considerations in trying to understand whether we can do DBS in a way other than just continuously delivering the electricity. So the last, I would say maybe decade or so, we have learned a lot about the brain signals. Usually when we put that electrode in and you deliver the electricity, that's all you're doing. But now what we have seen become available is the opportunity to use those same electrodes, not only to deliver the electricity, but to also record the activity of the brain. And what we have found is that there is a particular brain signal that seems to correlate with symptoms of Parkinson's disease. You may hear this referred to as the beta band or beta frequency oscillations. This just refers to a particular frequency of a particular neuronal electrical activity that happens in those deep brain structures that we're stimulating. And when that level is, the power of that signal is high, that usually means that people are experiencing more Parkinson's symptoms. And when the power of that signal is low, that often means that those patients are experiencing less. Okay. So we can actually track that now with these brain sensing devices. And the engineers have been able to devise a control mechanism based on sensing the power in that particular band that says, okay, this person seems to be having more Parkinson's symptoms, so maybe we need to ramp up stimulation. And oh, right now the patient seems to have better control or seems to have less Parkinson's symptoms that are present, and so we can reduce stimulation. So that's the idea behind adaptive. It adapts to the level of this beta frequency oscillation, and that's the most common control signal that's being investigated right now. And the idea is then that it just automates this process. So based on what an individual's brain is doing, then that stimulation can be adapted accordingly.
Is that currently happening, Dr. Shahed, or is that the future of adaptive?
So adaptive DBS has been undergoing clinical trials, and the trials are still ongoing. We don't have the complete data yet on what those outcomes look like. We have some preliminary evidence, but that is certainly something that we anticipate is going to be available in the near future.
Right. And how about potential negative side effects from adaptive DBS?
So based on the early results of this study that are available, we know that the adaptive DBS seems to work similarly to continuous DBS in terms of being able to control the symptoms that a patient is experiencing. Those studies showed that perhaps the electrical usage was a little bit less in the adaptive stimulation compared to those that were being delivered continuously. And we also saw in that preliminary report that there did not seem to be any new side effects or different or unusual side effects during the duration of the study to date. So far looking very promising, and we'll look forward to seeing the complete results.
Excellent. Now, people that have their DBS systems already in place for continuous DBS, are they going to be able to kind of switch over to this adaptive DBS? Is it a matter of programming, or is it a matter of the hardware?
I think probably the first thing, So I think the second part is super important, right? The hardware itself, like which device is implanted. So the brain sensing and the adaptive DBS capability is unique to the Medtronic deep brain stimulation platform. So anybody who does not have a Medtronic device will not be able to access adaptive stimulation, at least not yet. Don't know what the plans are for that in the future, but currently that is restricted to individuals with Medtronic devices. So if somebody has a Medtronic system implanted and they have the Percept platform, which is the most recent kind of set of hardware that is available and capable of doing the brain sensing, then when adaptive becomes available, they will be able to be considered for using that approach to programming.
And I guess at that point, we'll have more of the clinical study outcomes to say how valuable that approach will be.
Yes, absolutely. So I think these things are going to go under rigorous review, and once if they're approved, then they will become broadly available, and then people can be considered for it.
Right. Another terminology or term that I hear used is remote programming, and everything can be done remotely. It seems like from your controlling your car to home automation. But what exactly is remote programming when it comes to DBS?
Yeah, so remote programming, I think there are sort of different levels about which to think about remote programming. So remote, I think, just is the concept that you're sitting in your place and your clinician is sitting in another place. You're not in the same room together. And in different ways, you can actually achieve some degree of remote programming with all of the DBS devices. So every patient controller can be set so that patients can have the opportunity to use this, kind of control device to increase or decrease their settings. Now, some people feel very comfortable in doing that on their own once they're given the instructions from their physicians. Others would rather be able to do that under a supervised setting. One of the things that I do with my patients that can sometimes be very helpful is we're just doing a regular check-in and we realize, oh, maybe there's some opportunity. Can you just pull out your patient programmer, connect it to your DBS device, and bump it up a couple clicks? Right? And so that is a form of remote programming, and that can be done with all of the different devices should that capability be made available to you within the patient programmer. The actual remote programming platform where I, as a clinician, can connect to your device on my tablet that I usually use in the clinic, that type of remote programming is restricted to the Abbott devices at the moment. So if an individual has an Abbott device, implanted, then they can have their system configured in order to be able to access this remotely. And then what happens in that situation is I'm sitting in my office, usually the patient's sitting at home. We have a video connection, and we can actually access the full programming features of the device just like we would in the office. Right. So I can change any number of different things. I can turn the stimulation on or off. I'm the one that can do that controlling with my device. And I can see the effects. I can examine the patient. We can decide if that's working, if it's helping, if it's creating any side effects. So that is another way. I will say that there are situations where that works really well. First and foremost, if you have to have a great internet connection in order to make that possible. So sometimes that can be a little bit of a challenge. But I also think that sometimes with certain symptoms that patients are experiencing, it's harder to really do a full evaluation without being able to examine in person. And so there are certain situations where that might not be ideal.
Right.
But that will be up to the clinician and the patient.
Right. I do think, though, that it would be helpful from an accessibility point of view for patients that may be more remote or not able to come in for regular checkups.
Absolutely. I mean, I think one of the hardest things for some patients in terms of accessing deep brain stimulation is how close they are to the center and the number of appointments maybe that they have to come to. So I do agree with you. I think that would be an excellent method to have available to more people in order to increase access.
Right. And what is image-guided programming exactly?
Yeah, so image-guided programming is yet another tool that we have to try to hone in on the best settings for an individual patient. So when the surgeon is planning the procedure, they have to get very detailed images. And, you know, some of you may be familiar that there's often a frame that is used, and that's in order to really kind of calibrate where exactly that electrode is going to go and how they can plan that trajectory and be very precise. Those images are not often made available to the programmer, so the clinician who is actually programming the device, or it's kind of hard to do that, or it has been historically, let me put it that way. So now with these image-guided programming, what has actually been achieved is the opportunity to take those images that were used to plan, and usually a post-operative image that has a picture of the brain with the leads in place. And these can be kind of fused and merged together and then shown on the programming tablet to the clinician who is programming the device. And based on what we can then see on the image of that particular patient, it's very individualized. Here's their lead, here's the brain structure that we are trying to target. We can really zero in on where the stimulation should be delivered and how we can kind of adjust that field to kind of be in the best spot for that individual patient. So that's image-guided programming. Which, you know, has been available on the Boston Scientific devices. Hopefully in the near future will also be available on Medtronic devices as well.
Is that an advancement that you think is particularly important?
I think that any tool that we have that can help us be more efficient in our programming is always helpful. It's not only helpful for the clinician, but it's also extremely helpful for the patient. Sometimes these programming sessions can be lengthy, and that's a lot to do, especially that first one, you know, changing something and then doing all the examination, and, you know, it can just take a while. So if we can hone in on where we want to be, either by using the brain sensing or using the brain imaging, that's always a bonus, I think, for the entire team and for the patient. So I do think that, you know, it's hard to say which one is better. I think that an individual clinician may have more familiarity with one or the other technique. And I think that's really kind of the way that I would leave it. Whichever technique is being used, you'd like for your programming clinician to be familiar with that as possible and be able to take full advantage of all the different capabilities there.
And how long has this been in use? Do you know, Dr. Shahed?
So the image guidance in particular has been, I don't have a specific year on when that was first introduced. I believe it was in Europe before it came to the United States. So it's been a few years that has been available. And I think increasingly we're finding how advantageous it can be. So definitely a good tool to have in our toolbox as well.
Right. I'm just wondering for people that may not be this method might not be used for their particular DBS system. Can they ask for it? Is it something the clinician just uses on their own?
So for people who have had their stimulators in place for a while, I think that there then will be a process in retrieving images and merging them and making them available. I think that it's a fair question to ask if that is available on that particular device or with the tools that clinician has available within their group. There's actually different ways to kind of look at the images these days. So it's certainly, I think, a fair question, but there may be a lot of factors that determine how exactly that's available in somebody with an older or who has been implanted for a while.
Right. Another important part of the DBS equation is, of course, as you mentioned, the batteries that operate the implanted leads, rechargeable versus fixed, variations in size, and so on. What is the latest advancement when it comes to batteries?
I think the batteries, so all companies now have a rechargeable device. I think that's a huge advancement. So that is number one. I think as we have seen these rechargeables develop, we're also seeing more incremental sort of improvements in the design of the batteries themselves. So they're smaller, they're more efficient. We get better estimates of the battery longevity. That's a huge thing because it used to be, I remember when I used to send patients, I'm like, check your stimulator every couple of weeks and tell me if you start seeing the signal for, needing a battery replacement. So now we're getting much better predictions of what that battery life is like. So we can anticipate that. And I think that's a huge thing. The other thing that I think has been a huge advancement is the ability to safely do the MRIs and patients maybe having control of that a little bit, being able to put their stimulator in an MRI mode and then be able to get an MRI safely, which you can now do with all of the devices as well. Different MRI machines sometimes for some of the devices, but overall can get an MRI when needed and can get it done safely. And that's also part of just this battery design that allows patients to be able to do that. So then the other things that are there are just how much information that battery can store and whether it can do the brain sensing and things like that. So those are also the other kind of technological advancements.
Is there a point in time where you have to have the battery replaced? Is there a lifespan to that battery?
Yeah, so a regular battery, obviously, just like any battery, like your cell phone battery, as much as you use it, right? So it's going to depend on how high those settings are, and there may be a number of different factors that sort of determine what that is. Generally speaking, we talk about 3 to 5 years battery life for a, let's say, typical Parkinson's patient. That could be longer now, given sort of the new efficiencies that we've talked about. So there is certainly some data suggesting that is the case. With the rechargeable devices, we're talking about upwards of 15 years. So as long as patients are taking care of the devices, charging them, et cetera, and there aren't any other sort of untoward circumstances, et cetera, then, those should be pretty hardy and reliably, still able to deliver stimulation for, like I said, upwards of 15 years.
Is there any lifespan on the implanted hardware?
So you're talking about the electrode, maybe, and the extension wires. Yeah. So I think that it is not it's not a frequent thing that we have to go back in and revise the electrodes or the extension wire. Sometimes it happens. This may be due to either, in some circumstances, it could be normal wear and tear. Other times it could be related to some sort of event. Sometimes, like an injury, for example, if somebody falls or maybe there's some kind of an accident or something, those things can stretch. They're built to have a fair amount of, I should say, elasticity. So they're not, so rigid that there is a little bit of give in them. And so that allows some flexibility, but given the circumstance, there may be situations where they still get damaged. The other place that can sometimes happen is at the connections. And so those may just sort of over time have some issues, but again, not very common. And thankfully, having to replace those is not something we change far more about batteries than we do actual other hardware.
Right. I'd like to maybe go to a few of the questions that we had pre-submitted, and a couple of them actually have to do with what does DBS help with? Does it help with dystonia? Does it help with freezing and gait? We talked a little bit about this briefly in the intro, but I was just wondering if you could maybe go into a little bit more detail about the symptoms that DBS in general will help with.
Yeah, I think what we talked about was the on and the off times and maybe the tremor, but really DBS can help with most of what we call the cardinal features of Parkinson's disease. So what are those? Those are tremor, the rigidity or stiffness, the bradykinesia or the slowness, and then some of the walking and maybe some balance issues. And I say maybe because one of the really important things that we do when we are considering somebody for deep brain stimulation is a preoperative assessment. So it's not just, oh, I think it's time for DBS, go to see the surgeon and come back when you have the DBS in place.
Right.
So one of the things that we do is on-off testing. Okay, so we will have a patient with Parkinson's disease come into the office off medications, and we see kind of the worst of what the Parkinson's symptoms can look like. And then we have patients take their usual dose of medication. Sometimes we have to supplement a little bit given the circumstance, but we try to then re-examine them, or we do re-examine them once their medications kick in and they are on. And what this gives us is some people refer to this as the levodopa challenge test, but basically it shows us the degree of responsiveness of their symptoms to medication, whatever those symptoms are, whether it's speech, whether it's stiffness, whether it's walking, whether it's balance, whether it's dystonia.
Right.
So generally what we say is that if that symptom that a person is particularly concerned about gets better with levodopa, and it seems to be better controlled in the on medication state, then it will be treated with the deep brain stimulation. Because what does DBS do? It keeps patients on longer, right? So I think that's a really useful guideline for people to think about. So in the particular situation of dystonia, for example, a lot of people experience dystonia when the medications wear off. And that is, so if it's a wearing off phenomenon, then the fact that we're going to keep you on longer with a deep brain stimulator means that your dystonia will likely be better controlled. Some people may experience some dystonic symptoms when they're on medications as a part of their dyskinesia. And those types of dystonias will also get better because we're also reducing the amount of dyskinesia that people have. In the situation of gait, it's a little bit more complicated. To a certain extent, yes, any kind of walking or balance issues that are better with medication will also be better with DBS. But that is wrapped into a little bit of a more complicated conversation because those do tend to be some of the harder symptoms to maintain control over the time period of deep brain stimulation. So we always approach that one with a little bit more caution, but a careful evaluation is always the key.
So I guess until adaptive DBS becomes sort of more in use, it really depends on the patient's symptoms and relaying of their symptoms to their clinician as to how the programming is adjusted.
I think I might, I don't know that has so much to do specifically with the adaptive, right? So I think the adaptive is just the ability to say, yes, you need the stimulation now, and under these circumstances, you need this amount of stimulation.
Okay.
But whether the symptoms are going to get better or not with or without continuous or adaptive stimulation really still just depends on this on-off sort of conversation. Like when are the symptoms occurring? When are they bothersome? Are they treatable? I think, I think it's more just about the fundamental sort of characteristics of the patient that will allow us to be confident about whether that will get better after surgery.
Right. And are there any anatomical reasons a person would be ineligible for DBS?
Yeah, so anatomical, I assume we're talking in the brain. We have certainly come across situations where again, as part of the preoperative assessment, everybody gets a brain MRI, right? So then we find something that we weren't expecting to see. A couple of times, one of the cases that happened at some of the centers where I have worked was we found something like a meningioma that was in the way of where we need to go to get the electrode in. So then we had to stop, do the meningioma treatment first, and then proceed with the deep brain stimulation. So there are sometimes circumstances like that where there are other things on a brain MRI that might make it difficult to actually complete the DBS procedure. Sometimes that has to do with the actual target structure, and that may vary according to, sort of the disease state or what other background medical issues a patient has. So, there's a lot of careful thought that the surgeons have to put into exactly how they would approach getting that wire into that very precise area of that brain structure. It's not just hit the structure. It's also got to do with the angle at which you go in and all of these kinds of things. And so they're looking very carefully to see. But that's a major reason behind the preoperative imaging, to allow for surgeons to make the accommodations that need to be made, or to decide if this is not going to be easy to do without another procedure first.
Right. And are there other factors, not just anatomical, that may deem a person ineligible for DBS, such as an age cutoff or any other factors that you look for?
I think that increasingly we are recognizing that DBS, it's a quality of life question. Okay, so I think that in a number of different circumstances where we may have been cautious, and age is a good example of that, previously, we are increasingly understanding that there's a risk benefit that needs to be considered beyond just a specific cutoff. So, I think that a lot of these things are sort of relative. Age in particular is sort of relative. We know that as patients age, there can be other medical conditions, there can be other things that maybe make it hard for them to get through a deep brain stimulation surgery. So we are, again, thoughtful and cautious in our approach, but not necessarily precluding somebody from DBS just because of an age reason. Probably the one thing that we give another, like a major consideration to, is cognitive status. So again, cognitive meaning thinking and memory. So just like I talked about the preoperative assessment where we evaluate patients off medications and on medications, most centers are going to require that patients undergo what's called a neuropsychological assessment. And this neuropsychological assessment is a really careful, detailed assessment of all the different brain functions. So not just, the motor parts of the brain where we can measure things like tremor and rigidity and bradykinesia, but they're looking at thinking, they're looking at planning, they're looking at executing, they're looking at attention, all kinds of different brain functions. And if we see that somebody's experiencing a lot of difficulty in multiple different brain regions, or as a result of different brain functions, and they meet criteria for dementia, we have to be particularly careful about doing brain surgery in those individuals, because we know that they may have a higher risk of having more complications or further declines after the surgery. Again, it's a risk-benefit conversation. So I can say that at our center, we have actually also operated on patients who have more advanced cognitive difficulties, but always with a very, kind of careful preoperative conversation about the potential risks and benefits. And, we sort of make ourselves available to the patient and to the caregivers and the families if they feel that that is a risk that is worth taking. But we always sort of involve the patients in decisions at that point.
Yeah, I mean, that patient-centered care is really what is best for quality of life for patients.
Absolutely.
A couple of questions that have come up in the chat include this sort of what happens after surgery. So how often, for instance, is speech affected after surgery? Some people would like to know.
I think that's also a difficult question to answer in terms of specific percentages. I think that, a lot of the side effects of deep brain stimulation depend on, again, things like how well the electrode is placed, and then just what maybe programming techniques have to be used in order to minimize. So, I mean, could I induce speech problems in a lot of patients with deep brain stimulation? I probably could if I ramped it up enough. or in a certain place. So I think the risk is certainly there, but I think with all the different tools now that we have at our disposal, whether it's the brain sensing, whether it's the image guided programming, et cetera, even just the fact that the electrodes allow us to steer the current in certain directions, we can kind of move away from areas that cause speech problems and kind of preserve that issue that way. This should not be something that patients should feel as a major trade-off in their level of symptom control. And if it really is, then consideration certainly could be given to something like an electrode revision. So I think before we recommend that, though, we want to make sure that we try all these different things at our disposal to minimize that kind of a side effect.
Right. And you mentioned that gait is a complicated issue when it comes to DBS. What is the research out there between DBS and balance issues, and how does it help? Does it hinder? Does it solve any of those balance issues that people have, which lead to those falls that we all dread?
Right. Yeah. No. And I think certainly that's a kind of a motivating factor in some circumstances to consider something like deep brain stimulation, right? So I think, again, it gets back to this conversation about what gets better with medicines versus what's worse off medications, right? So if the balance is clearly better when you're on, then chances are that on state without the dyskinesia, with better control of your balance, is also going to be something that you will experience, certainly in the beginning time after deep brain stimulation. Over time, though, what we know is that, as I said before, DBS is not a cure. It's not preventing the Parkinson's from progressing. It's another tool that we have to help control the symptoms. But one of the symptoms that tends to be particularly hard to manage over time is the balance and walking issues. So these will continue to change, unfortunately, in Parkinson's disease, and they will be difficult to capture control of simply with deep brain stimulation adjustments. So that's why it's such a complicated issue. I think that if there's individual questions about that, as was mentioned at the beginning of the webinar, this is a conversation that you should have very specifically with your practitioner about your particular case.
Absolutely. Another question that's come up in the chat is, does DBS influence sleep? Any impact on the sort of RBD symptoms that we can sometimes have?
Yeah. So I think there's a number of different sleep issues, right, that people with Parkinson's can experience. And I think RBD, I'll take that one first because I think the answer is a little bit clearer. I don't know that there's evidence that DBS stops RBD. Okay. So I don't know that we can expect that. But what I do see a lot in my patients, and what I think the literature also supports, is that people do sleep better. And that may be just as a result of better control of motor symptoms. I think people may identify with the fact that they're uncomfortable at night. The last dose of medications may have been given. Maybe they wear off in the middle of the night. Stiffer. Maybe if they wake up, they have tremor, et cetera. Things like that really interfere with sleep. So I think there is evidence that people sleep better, and certainly a lot of anecdotal reports that patients tell me that they're sleeping a lot better after DBS.
Interesting. Maybe that's something I should consider. It's such an issue. Is there a benefit to having DBS earlier in one's time living with Parkinson's, and how late is too late? I think we addressed that a little bit with the age issue that we talked about. But is there an advantage to having it earlier?
I think there's a window of opportunity. That's the way that I really sort of explain it. And the window might open at different times for different people. This window usually is when, as we talked about, people are starting to experience the fluctuations and the dyskinesias, right? So medicine's kicking in, wearing off, and then having the involuntary movements. That's usually when we start thinking about it. Now, when does that generally happen? That can vary from patient to patient. But I think what our studies show, and what is currently sort of even approved from the standpoint of how early to do DBS, one of the some of the specifics that have been, sort of out there are that patients should have Parkinson's for at least 4 years, and they should be having these types of fluctuations and dyskinesias that are bothersome to them. So that's actually a fairly open statement, right? It doesn't say that the dyskinesias have to be this bad. It doesn't say that the fluctuations have to occur this often or have to be that bad. It just has to be troublesome to the patient. So again, this is all part of what we try to lay out when we are doing those preoperative evaluations for patients and try to tell that story of why this Parkinson's is problematic for this patient and we need to do a brain surgery. Now, as far as doing whether people do better, I think, when you're younger and you have less other kind of medical issues, you also maybe don't have as many of the potential Parkinson's issues that are harder to manage with deep brain stimulation. So the opportunity to benefit, could be better the kind of earlier you do it, but that doesn't mean to do it so early that you haven't given an adequate trial to medications. It's still a risk and benefit. Yeah. It's still a brain surgery.
Yeah, that makes good sense. Another participant asked, and this I remember coming up the last time we spoke, does DBS preclude the use of future surgical treatments such as gene therapy or stem cell therapy?
Yeah, I think, this question comes up a lot. And I think increasingly as we see what research is being done in terms of advanced therapeutics for Parkinson's, these are definitely questions that are on people's mind. The thing we've always said about deep brain stimulation, it is an implanted hardware, and such implanted hardware can be taken out. Okay. So I think that is always, the reversibility of a deep brain stimulator surgery is definitely there. And so if such a treatment were to become available that requires that there not be a deep brain stimulator in place, then it becomes an individual risk benefit analysis about whether it's worth it to take out a stimulator in order to get the new procedure. But can be done.
And that kind of leads into, you're mentioning it can be taken out, but one of our listeners wants to know, can you add leads based on advancing symptoms, or would there be a need to do that?
So adding leads is certainly it can be done. Usually if we're talking about doing that, it's because somebody has had particular difficulty getting symptoms controlled, yet we are certain that the DBS is doing something and we don't want to lose the effects that it does have. We just want to be able to add some additional benefits that are not being obtained. I would say that it's certainly possible, but maybe not a norm. And that should not be the first sort of approach to dealing with symptoms that aren't adequately treated. Right. There's a kind of fairly standard algorithm in the approach to troubleshooting a situation where a patient feels like they're not getting a good response or getting the response that they would like, or if they're having symptoms that are not well controlled. And I would definitely advocate that those are gone through first. And those may include things like completely reprogramming the device. It might include things like getting imaging in order to make sure that the electrode is in the right place. It might be just going through the whole story all over again and making sure we're kind of dealing with the condition that we think we're dealing with. So all of those considerations should be made first. And if after that there is reason to believe that adding an electrode might be beneficial, then that can be considered.
And that kind of leads into another question that a listener had, was if one programmer can't find an optimal program for symptoms and side effects, is it okay to ask for another expert opinion?
Yeah, I know people often feel very kind of weird about asking for second opinions. And, my sort of personal philosophy, I can say, is that, it's really important for you to feel confident in the treatment that you're getting as a patient. And if you feel like there's questions, then it should be, well within your rights to be able to ask for, another opinion. And I think that sometimes patients may go and ask for another opinion and they will find different solutions. Sometimes they may ask for another opinion and they may find that what's being done is the best that can be done. Right. So if that gives confidence one way or the other, then I think that is an important aspect to pursue. So I encourage my patients who might be interested in it in getting another opinion. And at minimum, I'm going to learn something from the whole process as well. So it certainly, it can be helpful. So I think it's okay to ask for that.
Right. So as our time comes to an end, Dr. Shahed, I would like to ask you one last question, or it's two parts basically, but what is the most exciting potential advancement in the field of DBS technology coming down the pipeline? What do you see for the future of this field of surgical treatment?
So, I think that, there's a couple of things. I am actually super excited about the possibility of adaptive DBS. I think we'll learn a lot about how DBS can work and how it can help people and how it can help people in a better way. So I do find that to be very exciting. I think we are learning a lot about these brain signals. This particular version of adaptive DBS rests on that one particular brain signal that we're talking about, but there's a whole lot of research that's going on looking at other brain signals that might be present and what that might indicate about a patient's particular disease. One of the things that we're doing at our center is looking very carefully at the non-motor symptoms of Parkinson's. And I think it's a really intriguing possibility that even though we focus so much on the motor symptoms with deep brain stimulation, that we could possibly do a better job of addressing the non-motor symptoms as well. And I think that's a really exciting possibility, because if we can be a little bit more comprehensive in how DBS can help, I think that may also sway a lot more people to considering the therapy in their own situation. And kind of that gets back to the whole sort of access issue and how many people are actually getting the therapy that could help them.
Yeah, I think that would be very exciting, considering a lot of the non-motor symptoms affect quality of life even more than the motor.
Yeah.
So that would be very exciting development indeed.
Yeah.
Thank you all for kindly joining us today, and particularly to you, Dr. Shahed, for your time and expertise. I know I did, and I'm sure our listeners also found the discussion helpful and educational. So thank you very much.
Thank you for having me. It's my pleasure.
And remember, everyone, we may not have a choice in our diagnosis, but how we face the challenges that this disease brings is really ours to define. So choose to optimize your quality of life, educate yourself, empower yourself, and celebrate your daily victories. Thank you.